Alrighty, here we go. So it's my pleasure to introduce Dr. Melissa Boswell. She is visiting us from Stanford, and she is going to be talking about digital tools to enable large-scale access to biomechanical assessment. She got her bachelor's degree at the University of Akron in biomedical engineering before going to Stanford, and has a really cool dual disciplinary kind of degree tread with psychology with Dr. Aliyah Kroom and bioengineering biomechanics with Scott Delp. So standard presentation rules, phones off, all that nice stuff. At the very end, when there's questions, wait till I hurl this microphone at you so our colleagues can hear us. Ready? Ready? All right, thank you.
Good. Thanks for the introduction, and thank you for having me here. I'm really excited to have the opportunity to talk to you today about some of my work. I've really enjoyed my visit so far. I've had some great meetings and conversations about how my work might be able to fit in here and complement some of the fantastic work that you all have going on here. As Zachary mentioned, I am a postdoctoral scholar in bioengineering in the neuromuscular biomechanics lab, and that spans orthopedic surgery, mechanical engineering, and bioengineering, and then was co-advised in psychology by Dr. Aliyah Kroom. So many of us hear a lot now, and many of us research many of the benefits of movement, both the physical and mental health benefits of movement. But movement is also essential for expressing ourselves, for connecting with each other and interacting in the world. And when I experience times in my life or my loved ones' lives where movement has been restricted by things like injuries or diseases, it really showed me the impact that had on being able to participate in life, and it made me want to study biomechanics in order to help people with these conditions and help people really enjoy life as fully as possible. And one such condition that can severely limit mobility is knee osteoarthritis, and it currently poses a massive global burden. It's characterized biologically by the degradation of the cartilage at the ends of the bones, and it can result in significant pain and stiffness. So it affects over 90 million people globally with a 45% chance of developing it in one's lifetime. Patients with osteoarthritis often have comorbid conditions such as heart disease. They tend to have lower levels of physical activity and even higher levels of depression than those without osteoarthritis. So while we often think of osteoarthritis as a disease of wear and tear, more mechanical damage, it really is a multifaceted disease that affects an individual at all levels of life. Unfortunately, there's no known cure for osteoarthritis, so developing treatments to manage the symptoms and slow progression is a grand challenge for the field. The typical treatment trajectory is to start by suggesting lifestyle changes, things like anti-inflammatory diet and exercise, as well as anti-inflammatory medications or steroid injections, and if those fail to help, then a total knee replacement or arthroplasty is the main surgical option. Unfortunately, lifestyle changes aren't always used or adhered to. I know that I've been guilty of this when given physical therapy exercises that I don't always do, but with osteoarthritis, patients then tend to end up moving more quickly towards injections and surgery. And I believe there is a key step missing here that could help improve this treatment trajectory, which is assessing one's biomechanics. And we know from a biomechanical perspective that overloading the knee joint is a contributor to osteoarthritis, and by evaluating the biomechanics of the joint, we can design more effective ways for people to move that can offload the joint, but they continue to stay active and mobile, which is beneficial for them in many ways. And this can improve pain and potentially even slow osteoarthritis progression. However, biomechanical assessments have traditionally been limited to laboratories with expensive and technical equipment that isn't scalable or accessible to most people. So there's this really large need to develop digital tools that can assess biomechanics at a large scale. And if we can do that, then perhaps we can prevent or prolong the need for medications and surgery by inserting biomechanical intervention as an additional step in our osteoarthritis treatment. And I believe if those same tools can be coupled with psychological intervention to change mindsets and therefore make lifestyles more likely as well, together biomechanical intervention and lifestyle changes can really provide a more holistic and healthy treatment plan. So the overall goal of my work has been to develop tools and methods to improve access to digital biomechanical assessments for individuals with knee osteoarthritis. In this talk, I'll first present a project that demonstrates the feasibility of personalized biomechanical intervention for individuals with osteoarthritis with a smartphone camera. Then I'll share a second study where I evaluated the psychological construct of mindset in people with knee osteoarthritis and how that relates to the use of movement for symptom management, which could influence engagement with digital tools. And then finally, I'll share a third project where I developed a platform and protocol to develop a nationwide at-home biomechanics study that can detect osteoarthritis with a smartphone camera. So I'll start towards this work with work towards a mobile personalized biomechanical intervention. So as I mentioned, we know that overloading the knee joint is a contributor to osteoarthritis, but the way to directly measure knee joint forces requires an implanted sensor. And this is really intrusive and not very feasible for an arthritic knee. A surrogate measure for internal knee loading is the external knee adduction moment. And this moment occurs in the frontal plane and rotates the tibia with respect to the femur. And you can see here that this creates a force in the inside of the knee or the medial knee compartment. So this peak knee adduction moment is related to the presence, severity, and progression of medial compartment knee osteoarthritis. And in many patients, learning how to walk with a reduced foot progression angle, this means walking with their foot pointed further in, can actually reduce the knee adduction moment. So you can see in this plot here, we had the stance phase of gait on the x-axis which is when the foot is on the ground. We had the knee adduction moment here on the y-axis, normalized by body weight and height. And this black line is the individual walking normally, and this orange or reddish line here is when the individual is walking with their toes pointed further in. So you can see that this modification reduces this peak knee adduction moment. But this isn't an effective strategy for everyone. And in fact, for some people, it can actually increase their knee adduction moment, and they may instead require the opposite intervention, which is walking with their toes pointed further out to decrease their knee adduction moment. So it's not something we can freely prescribe to anybody with knee osteoarthritis, and previous work shows that personalizing this foot angle is really the most effective treatment and leads to the best outcomes in pain as well as cartilage microstructure. But the current workflow for determining a personalized foot progression angle is done in a biomechanics laboratory. So the individual comes into the lab and walks with varying foot angles over force plates and with motion capture equipment. We process the data, often manually. We calculate the knee adduction moment using inverse dynamics, and then from that determine the foot angle that most effectively reduces the knee adduction moment. So while changing one's angle of their foot during walking may be a simple and effective strategy, it currently requires this full biomechanics laboratory. In recent years, there has been tremendous growth, as many of you know, in tools that enable biomechanical measurement outside of the lab, so things like inertial measurement units, wireless electromyographic sensors, shoes instrumented with pressure sensors, and pose estimation algorithms, which can predict the location of joints from 2D video. And motion analysis from 2D video is a particularly exciting opportunity, as 84% of the global population owns a smartphone and could then have access to their own pocket-sized tool for quantitatively self-assessing their movement. So here's a video of the pose estimation algorithm OpenPose in action. And these algorithms have been used to make fun videos, and you can see, on average, accurately detect poses. But what I really wanted to know was, are they robust enough to enable estimating important health-related measures like the knee adduction moment? So I proposed that the joint location key points detected from pose estimation algorithms could be input into a machine learning model that could then predict the knee adduction moment and the most suitable gait modification. But we currently don't have appropriate data sets with simultaneous 2D video and motion capture that could train a model to do this. So instead, I tried the same approach, but with using motion capture marker positions as the input to a machine learning model that predicts the peak knee adduction moment. I built 3 models with slightly different inputs. So the first model used the 3D marker positions as input, while the other 2 models projected the 3D positions into either the frontal or the sagittal planes to replicate joint position inputs from 2D video. And then the model predicted the peak knee adduction moment during each step, which we also used to calculate the knee adduction moment changes with varying foot progression angle modifications. So the data set I used was from in-lab studies with participants with and without knee osteoarthritis walking naturally and with foot progression angle modifications. And I split the data such the test data contained participants that the model hadn't seen before. When I evaluated our model on this test set, found that the model with the 3D positions accurately predicted the peak knee adduction moment with an R-squared value of 0.78. And when using only the 2D positions from the frontal plane, we obtained an R-squared value of 0.85. So here are the results from 2D video shown on this plot. On the x-axis is the normalized peak knee adduction moment from inverse dynamics, and on the y-axis is the value predicted by the machine learning model. Each step here is, or each point is a step, and each colored cluster of points represents data from a set of steps from an individual. And these results were similar to, if not better than, previous studies aiming to predict the knee adduction moment from ground reaction forces and anthropometric measures, as well as force instrumented shoes and inertial measurement units. But predictions from 2D video would be cheaper and require less equipment than with force plates or an inertial measurement unit system. Here are some results testing how accurately the model could classify changes in the knee adduction moment with toe in and toe out foot progression angle modifications. So again, a perfect prediction would be along the y equals x line. But the goal of the classification problem was really to predict an overall increase or decrease in the knee adduction moment, so to get the points either in the upper right or lower left quadrants. And our model was able to do this with 92% accuracy. Oftentimes, machine learning models can be a bit of a black box. So I tried a technique called saliency analysis to identify which features that when changed had the greatest effect on the predicted knee adduction moment. So to do that, I set up an equation where we took the partial derivative of the peak knee adduction moment with respect to each input, so the position of each joint, and averaged that over the number of steps for each individual and the number of time steps, and then normalize that by the most salient feature, so we would get a position, a saliency between 0 and 1. Interestingly, for the 3D input positions that the saliency analysis identified as the most influential for the knee adduction moment predictions corresponded to kinematic changes that have been shown to affect the knee adduction moment. So for example, the superior-inferior positions of the iliac spine relates to contralateral pelvic drop, which increases the knee adduction moment. Medializing the knee during gait is a suggested mechanism for knee adduction moment reducing interventions. And we also have the medial lateral position of the C7 vertebrae, and that relates to trunk sway, which is also shown to affect the knee adduction moment. So a limitation of our model is it was trained on a single data set in one biomechanics lab and on a treadmill. Every lab and clinical setting are different in both their setup and equipment. So the model would definitely benefit from some additional training on data from various sources. And in the future, it would be ideal to use video as the model input, but our study is a good first step towards showing that it might one day be feasible to have an app where a clinician could take videos of their patients walking with different gait modifications and select which one would maximally reduce knee loading for each patient. So in assisting with this clinical trial where we collected the data for personalizing the foot progression angle for osteoarthritis, I realized that even if we're making biomechanical interventions accessible to people, and even if they're beneficial, it doesn't necessarily mean that an individual will adhere to it or be more physically active because of it. And this ended up being a big challenge of the study. But it made me really curious about how thoughts about osteoarthritis and exercise may be influencing one's relationship with movement. So in study 2, I sought to better understand how psychology influences engagement with exercise, which included understanding mindsets about exercise and then improving them. So I think the term mindset is a word that many of us are familiar with nowadays, especially with regard to intelligence. Carol Dweck, she kind of coined the phrases or the terms growth mindset and fixed mindset about intelligence, where growth mindset is the mindset that intelligence is something that can change over time, versus a fixed mindset is something that, a mindset that individuals think that intelligence is something that we're born with, it's more innate, and it can't really change over time. And this is shown to relate to outcomes in students. And we also have mindsets in other domains, for example, exercise. One mindset that may be relevant here is actually the extent to which individuals view engaging in exercise with less appeal-focused qualities, so things like difficult, unpleasant, or stressful versus more appeal-focused qualities like easy, pleasurable, and relaxing. And I'll refer to this as the exercise mindset. And this mindset is a 7-question, 1-factor scale that demonstrates strong internal consistency and test-retest reliability. In students, it's been shown that the exercise mindset can be changed to improve physical activity involvement, but mindsets hadn't been evaluated in the knee osteoarthritis population. So to do that, I ran an online observational study, which was completed by participants with knee osteoarthritis at baseline and then repeated 3 weeks later. And I found that mindset was correlated with future physical activity. So you can see here a higher physical activity score, which we used the physical activity scale for the elderly, was associated with a higher or more enjoyable exercise mindset. And this relationship was consistent even when controlling for demographics, health, and knee pain and stiffness, with a coefficient of almost 39. I standardized the continuous independent variables here, so this result means that a 1 standard deviation increase in the exercise mindset was associated with an increase of almost 39 points in the physical activity scale for the elderly. And for context, an increase of 39 points in this scale would correspond to an increase in physical activity, performing physical activity for 2 to 4 hours per week, seldom too often. Similar to other studies, we found that 50% of participants reported using medications or injections to manage their symptoms, while only half of that, about 27%, reported using physical activity. And when comparing mindsets across these groups, we saw people who use exercise alone, which is this group here on the right, or those who reported using exercise and medication and injections, have a significantly more enjoyable mindset than this group here on the left who reported using medication but not exercise to manage their symptoms. So the survey helped us better understand relationships between mindset and physical activity, but then we wanted to know if we could improve them. So to do that, I used an iterative mixed methods approach to develop, pilot, and refine a digital mindset intervention. And this consisted of the quantitative and qualitative studies that I just described, as well as I had an undergraduate student working on a project where he used some unsupervised machine learning tools to scrape Reddit posts about osteoarthritis and evaluate the types of themes around concerns that individuals had with knee osteoarthritis. I conducted semi-structured one-on-one interviews. We used mindset theory and then multidisciplinary expertise, so experts from orthopedic surgery, from psychology and behavioral sciences, even the English department and narratology, as well as bio and mechanical engineering, to develop our intervention, which we pilot tested. And throughout this whole process, I maintained patient feedback and participation throughout, including in the actual intervention itself. So I was happy to read about and learn more about the focus of human-centered research here, and that's definitely something that's been a priority in my work. So this led to the program named Rethinking Osteoarthritis, which has 4 modules, each with a series of short films and reflective activities. In each module, we have experts on the topic share the latest research, individuals with osteoarthritis share their experiences, and we used animations and videos to help instill some of the ideas that we're conveying. In Module 1, we aim to help individuals better understand osteoarthritis and common misconceptions surrounding it. And I'll share a short clip here so you can just get a flavor of what the intervention was like. I don't know if you can.
There are a few reasons for misconceptions about pain. Maybe a friend or family member with osteoarthritis shared their painful experiences, or an advertisement for arthritis medication highlights its painful nature. Hearing this can change your expectations of pain, leading to increased sensitivity to pain signals.
In our culture, we tend to rely heavily on imaging to explain symptoms. But the fact is, the severity of osteoarthritis on X-ray or MRI does not correlate that well with pain that one experiences. There are many examples of people with osteoarthritis on imaging who have low levels of pain and high physical function.
So in Module 2, we taught what type of exercise is beneficial for improving osteoarthritis symptoms and joint health, as well as the many benefits of movement and even beyond just helping with osteoarthritis. The third module implicitly targeted the exercise mindset and presented the opportunity to rethink physical activity as something that we want to do because it's fun, it's social, and relaxing or engaging. And in the final module, we take what we call a meta-mindset approach, and in this approach, we explicitly talk about what mindsets are, and while they are not right or wrong, they do have an impact. And we concluded here with tools for adopting more helpful mindsets about osteoarthritis and exercise. And I'll share a quick clip here to just share a little bit more about how we present mindsets.
But the important thing to remember is that the mindsets we hold or choose to hold can make a difference. So empowering yourself with a mindset that osteoarthritis is manageable or even an opportunity can help revitalize you with energy to engage in the tools you need to manage your osteoarthritis. And as a result, your body can become inspired to function as well as it can and improve your overall health.
The advice I would give to someone recently diagnosed with osteoarthritis is that it doesn't define them, and to think about it as a new opportunity to try new activities that they might not otherwise have tried.
So I piloted this program in 21 individuals with knee osteoarthritis across the U.S. and found that individuals' exercise mindset significantly increased to a more enjoyable mindset about physical activity by an average of about half a point. For reference, a previous study found that in students just a 1/10 of a point higher exercise mindset score led to an increase in fitness class attendance. So we were really excited to see this result, as well as some of the direct participant feedback. So I added some quotes here from participants to sort of add some color to the results that we were getting, where this participant said that initially they had this preconception that exercise should be exhausting and not pleasurable, but after the intervention, they could focus more on the feel-good effects of exercise. I also measured mindsets about osteoarthritis, which measures the extent that one views osteoarthritis as a catastrophe or manageable or even an opportunity. This is scored from a 1 to a 6, and we found here that individuals' mindset about osteoarthritis significantly increased to a more adaptive mindset by an average of about 0.9 points. We found on average participants strongly agreed that the program was accurate, enjoyable, helpful, and relevant, and agreed that the information was new, which makes us optimistic that the program will be beneficial for individuals with knee osteoarthritis. I also did some video interviews with patients, and I wanted to share some of their perspectives on it.
Before, I've been thinking that very soon surgical intervention might be inevitable. But there are things that you can do. You know, you can keep active, try to keep yourself social and keep a positive mindset. And that's, I think, what gave me a more positive outlook.
Exercise done correctly is not going to worsen it. That was another big thing that I learned from that. Rather than exercise, think of it as play, fun. You're engaging your body in a good way.
You know, you think about it to yourself. Oh man, this is gonna get worse. But that was me doing that to myself. And that part of what the video said about your mindset. Once your mindset got right, I was like, no, I'm still pretty good. I'm still can do this.
I think the videos have really helped me with my mindset, and that I'll be able to change my mindset and exercise and become healthy and strong as I need to be. So in 6 months, I'll drop you a line and say, guess what? No surgery. Guess what? I'm hiking up and down those hills.
So this was really exciting to see and get this feedback, and it's inspired us to now just test the intervention in clinical trials. So currently in my postdoctoral work, I'm leading a couple of clinical trials to test if this digital intervention improves pain and physical activity levels through changes in mindset compared to typical education alone. And for so long, I think medicine has focused on healing the body, but if we can harness the power of the mind and integrate the mind and body together, which is something that I think you all also agree with and have a strong foundation of research here for that. I really think that we can design for optimal intervention, compliance, design, and outcomes, and really have the greatest impact on health and well-being. So now I've talked about two different digital interventions, one for biomechanical intervention and one for psychological intervention. Typically, the outcome measures for biomechanical interventions are measured in a lab, and psychological intervention outcomes are measured through self-reported surveys. In order to, though, objectively measure the effects of these interventions, we need a digital and quantitative means to measure physical function. So in this final study, I'll present a mobile platform and algorithm for quantifying a functional test with only a smartphone. So sit-to-stand transitions are widely used in clinics to test physical function by measuring the time to complete the test with a stopwatch. However, movement is a key determinant of sit-to-stand strategies, and in-lab studies have shown that kinematics such as joint angles can give additional health insights above just timing alone. Because of that, we chose to focus on the most common variation of the sit-to-stand test, which is a 5-repetition sit-to-stand test where an individual goes from sitting to standing 5 times as fast as possible. During the study, participants collected a video of their sit-to-stand test at home using a smartphone. So we suggested that individuals had somebody record the test for them, standing at about a 45-degree angle, hoping that we would get information from both the frontal and sagittal planes from participants, and then suggesting that they stand about 5 to 10 feet away so that the full body of the participants could be in view of the camera. The video was uploaded to the cloud, and the computer vision algorithm OpenPose detected joint locations in each frame throughout the movement. We did some additional data cleaning and processing on the results of these out-of-the-box algorithms. So, for example, we instructed the recorder to record on the right side of the participant, but for consistency, we would horizontally mirror key points in cases where participants were recording from the other side. We also normalized the data across participants by dividing the coordinates by the subject height in pixels. We then computed the key transitions of when the participant rises from the chair and returns to sitting by using the nose marker's local peaks in the vertical axis. And then in addition to time to complete the task, we computed biomechanical parameters. So for example, we calculated trunk flexion, which was defined as the angle between a vector from the hip pointing vertically along the camera frame and a vector from the right hip to the neck. And then to compute marker speeds and joint angular velocities and accelerations, we used the discrete derivatives, divided them by the frame rate. So from the user side, this looked like going to our website, sit2stand.ai. They completed a series of qualification questions and also completed informed consent digitally and asynchronously. They then got test instructions through both video and written instructions. And then after recording and uploading the test, they completed a health survey. In this study, close to 500 individuals completed the study entirely self-guided across 35 US states, which is over 35 times the median number of subjects in traditional biomechanics studies in just a few months with minimal researcher time and resources required. Because of the accessibility of the study, we were able to collect a fairly diverse sample. So in the 405 participants used in the final analysis, we had an age range from 18, which was the minimum age to participate, all the way to almost 100 years of age. We had a range of BMIs from underweight to obese, about an even distribution of sexes, as well as a range of different ethnicities and races. And here are the many different videos we collected from across the country. It was really amazing to see all of the places and ways that people perform the test. So they would perform the test in their living rooms, their kitchens, even outside. And from these videos, we got a glimpse into the many different ways people perform the test. And I'll zoom in on a few examples of these different movement strategies. So in this first video here, you can see a participant who appears to go from sitting to standing fairly easily and with control. Next is a participant you can see who uses or creates some momentum to stand up by leaning further forward. And they have knee osteoarthritis, which I'll share more about. Here's a participant who also leans forward, but it seems like they do that to optimize for speed rather than minimizing the lower body strength needed. And then finally, we have a participant here with a movement pattern that falls somewhere between these other strategies. I first compared the results of this study to past in-lab studies. And similarly, I found that longer times to complete the test were associated with an older age, which is shown in the plot here, Longer times were also associated with a higher BMI and lower physical health. Also found that larger maximum trunk flexion when going from sitting to standing was associated with a diagnosis of near hip osteoarthritis, even when controlling for age, sex, BMI, and time. And it also was associated with increased age. And this relationship between trunk flexion and osteoarthritis indicates that the kinematics we are obtaining from video may give additional insight about health and physical function than just timing alone. Larger trunk flexion among those with osteoarthritis also makes sense from a biomechanical perspective. So compared to a typical sit-to-stand, which is shown on the left here, with a larger trunk lean, which is shown on the right, the knee joint center is closer to the ground reaction force, and this reduces the knee joint moment. And it's been shown that with a link segment model like this, just a 20-degree increase in trunk flexion reduces the knee joint moment by about 30%. Our large and diverse participant pool enabled exploratory investigation in different study population subgroups. And in such analysis, we found trunk flexion angle differed across racial and ethnic groups. And because of these two groups were non-parametrics, shown here are the results from a Kruskal-Wallis test and a post-hoc Dunn's test. And there have been very few studies examining differences in biomechanics across races, just because of the typically small sample sizes. And so our finding really is hypothesis generating, and more studies need to be carried out to better understand these differences. But it is clear that we can't assume similarities between different racial groups, and future studies need to make more diverse study samples a priority. In individuals 50 years of age and older, greater trunk acceleration was associated with higher mental health. These findings are also hypothesis generating, but it is exciting to see that there may be relationships between mental health and the way that we move. And perhaps movement can complement biological markers in understanding and predicting mood disorders and cognitive performance. So while it was exciting to see all of the places and the ways that people perform the test, this inconsistency was probably also the largest or most significant limitation of the study. So for example, participants used different chairs and the camera angle varied. In our study, we asked participants for their feedback, and I think that this, in combination with experts and human-computer interaction and design, we can really make digital tools that are more precise, accessible, and dynamic. Overall, the study shows that digital biomechanical analyses are possible, and they have the potential to become a supplementary endpoint for decentralized clinical trials and as an at-home health monitoring tool in osteoarthritis and other domains. So in summary here, I developed a machine learning model to predict knee loading from inputs that could be extracted from 2D video and demonstrate the feasibility of personalized biomechanical intervention with a smartphone. I evaluated the psychological construct of mindset in people with knee osteoarthritis and found that it relates to physical activity levels, as well as developed a mobile mindset intervention aiming to shift mindsets about osteoarthritis and exercise. And finally, I developed a platform to deploy nationwide at-home self-guided biomechanics study, and with this large data set, was able to explore new relationships between biomechanical parameters and measures of health and well-being. Throughout these studies, I focused on knee osteoarthritis, but I believe that these digital tools and methods can be applied more broadly to other diseases, as well as the larger general population. And I think the limitations of the studies I just shared can help guide and inspire the next generation of digital biomechanical assessments. For example, in the future, we'll want to go beyond just joint angles and obtain mobile measurements of muscle activations and internal joint loading. And we may be able to do this by using movement information in natural settings to inform musculoskeletal and mechanical models. I'm really motivated by the potential impact of biomarker applications in early disease detection and remote treatment monitoring. So in collecting large biomechanical data sets in combination with other biomarkers, we can lean on developments in machine learning to really understand, combine, and glean insights, such as disease signatures from these high-dimensional and heterogeneous data. In the sit-to-stand study, the pose estimation algorithm showed less accuracy when people wore loose-fitting clothing like skirts or sweatpants, or if individuals had a higher body weight. So I also think it's important to use more diverse and larger data sets to be able to develop and retrain less biased algorithms. And finally, the interdisciplinary nature of my work was instrumental in all of the studies that I presented, and I really believe that the future of rehabilitation and engineering lies in this interdisciplinary approach, or interdependent approach, as I've heard about today, to digital health intervention and monitoring, as well as making tools and data open source so we can really support honest and rigorous science. The at-home sit-to-stand study that I presented today was published in Nature Digital Medicine just last week, and with it, all of the code, the web application, the code for the analyses, and all the data we collected were freely released. And this has been the case for all of my studies and something that I hope to continue, plan to continue moving forward. So by developing usable, accessible, and engaging tools, my long-term vision is we can deploy these tools to quantify biomechanics as a marker of health over one's lifetime. So for example, with these tools, may be able to detect ACL injury risk, recommend specific strengthening programs, detect osteoarthritis and prescribe personalized gait modifications, and warn individuals at risk for falling. And in that way, we can apply biomechanics in the real world to help people move better and safer, and really leverage biomechanical measures as a new biomarker of health. And I think as we establish biomechanics as a marker of health, I see it playing a key role as a metric in digital healthcare, being able to combine biomechanics with other measures from the individual as well as the individual's environment to really have a full holistic view of an individual person, and then being able to input that data into data-driven models and leverage musculoskeletal modeling and field knowledge to have more personalized interventions, as well as utilizing the expertise from behavior science, human-computer action, to make these interventions more accessible and engaging. And overall, I think being able to predict, intervene upon, and monitor health risks and diseases. I just wanted to end with a quick story. So I host a biomechanics podcast, and a few weeks ago we interviewed a really amazing individual who uses a wheelchair and is really passionate about exoskeleton research and how we can get exoskeletons into the hands of users. And he motivated this passion really beautifully by saying that it's the ability to choose your own mobility and to go where you want to instead of only where you can. And I really hope to continue to help individuals move in the ways that they want, so we all have the opportunity to live the lives that we want to live. So thank you to all of the amazing people that made this work possible, including both of the labs I've been part of and my funding sources. I'm really happy to take any questions and continue discussions.
You know the drill. Questions? I'm just going to hand it to you.
Hey, yeah, thanks for giving the talk. When you do that gait analysis with the inverted, everted foot, are they wearing shoes or is it barefoot? And how do you think that might affect some of the joint angles or the moments?
Yeah, that's a really good question. So they were wearing shoes. How that might be affecting the individual, I think there has been research shown in terms of like wedged insoles that can affect the knee adduction moment. I know that increasing stiffness in the shoes can change the ground reaction forces, which could affect the moment. But I would think if the cushioning is kind of overall, I would guess like maybe just like flat or like consistent, I guess, all around, it might not affect the inversion or eversion of the foot. But I think that is an interesting question. And like if an individual then like chooses to wear a different type of shoe, like might that affect their results? But I think doing the study in the footwear that they are using normally to walk around was the approach that we took. Yeah.
Actually about the same thing on the toe in and toe out piece.
Sure.
Did it make a difference on whether they had a more varus or valgus knee, and hip width and everything else? I mean, and also were you actually able to train people to change their toe in and toe out? I mean, that's something that's highly ingrained. I've walked for a long time pigeon-toed according to my entire family, but I just feel like it's straight.
Yeah, that's a great question. So starting with, does knee alignment or other parameters affect their response to the intervention? Yes, we did another study that we've published led by Scott Ulrich, who looked at some of the other biomechanical parameters and as well as some of the other inputs into the model to see which ones were most predictive. And I know knee alignment was a significant predictor of which intervention was best for an individual, but I can't remember the extent to that. We also looked to see if it would affect hip moments, as people might have hip osteoarthritis as well. So I don't know the effect of sort of the other biomechanical parameters, but I know that it didn't significantly change the hip moment. And then in terms of adapting the intervention, so we gave biofeedback to people during training. So they had vibrotactile sensors on each side of their leg and would get a little buzz whether they should move more to the right or the left. And we would bring them in, I want to say, every few weeks, and then started spreading out to every few months, so it was over an entire year. And we were able to see that near the end of the study, where we didn't have training, we just brought people in and tested their retention, that they were able to adopt a new foot angle. But I think that really did, like on average, but I think it did depend on the person for that.
Do you think that they actually continued that with their normal gait, or they just did it while you were watching them? Sorry.
Yeah, I mean, that's a great question, which I can't really answer, except to say that we did see changes in cartilage microstructure in addition to changes in pain. And for the intervention group, which is where we had them change their foot angle, those changes were more positive versus the control group. We told them that we're making their foot angle more consistent, where basically they were just training to walk at the same foot angle that they were already walking at.
I'd actually like to touch on that same question.
Okay.
For dancers, we're trained to have toe out.
Yes.
And I was just curious if in your studies you looked at professional dancers, particularly ballerinas or male ballet dancers as well. Do their knee joints wear out sooner because of that moment?
That's a really interesting question. I think about that a lot because I was trained as a gymnast, and I guess I kind of have the opposite, where I walk with my feet pointed straight and kind of one foot in front of the other. And I don't know for ballerinas, but I know that gymnasts tend to have a higher incidence of hip impingement, which is a surgery I actually had to do myself, but I'm not sure. We mainly were studying individuals with knee osteoarthritis. I'm not aware of their background, their sports background. It would be interesting, I think, to look at that, but also maybe hard to tell. I think with an older population, whether that's due to, I guess, kind of teasing apart what the development of osteoarthritis was due to. That's a good question.
Thank you very much for the great talk. It's a lot of work squeezed into a half hour. On the first set of studies in the CAM models, were those unilateral models, or were they bilateral averages across the knees?
Okay. Or they unilateral? Okay, so were they for like one knee, or were they for just
yeah,
for
were
both
they?
of them?
So I mean,
Yeah.
OA. A lot of people with it starts in one joint, right? They may end up with it in the opposite joint, but for the healthy people as well as those with OA, most likely they had dominant OA in one knee. So were those models on that side only, or were they average across?
So we didn't average them, but we did use both sides individually.
Okay.
And we mirrored the left side over to look like the right side in the model. So we did consider each of the joints just separately.
Gotcha.
Yeah.
And then my question on the third set of studies, with the trunk lean that you talked about, did you look at leg length versus trunk height as a potential influence on that? Because a lot of people have, relatively short trunks, long legs, and then some have the opposite.
Yeah, that's a really good question. We didn't look at that. We did normalize for height generally, so we could look at that ratio. And I think that I think there's a lot of interesting questions that we could dig into, which is why I'm excited that the data set is available to do some additional analyses, especially with the videos themselves being released. So we could also potentially use algorithms that, as they continue to get better, to better evaluate the videos. Yeah.
Bonus question.
Okay.
So you're computerizing all of this, and so the rise of AI can't help but raise the question of, are we going to be walking around or having other people's cell phones happen to just be pointed at us and assessing our health and then uploading it to the cloud? Are we going to be seeing osteoarthritis advertisements based on just the ambient cameras as we walk about?
Yeah, that's a good question. I mean, considering I think we would get osteoarthritis advertisements if we're just speaking about osteoarthritis, I could imagine that that might be, I don't know. I think there's a lot to learn and consider regarding the ethics of these big data sets that we're collecting, and more of the philosophical questions. So I think that's a great point in terms of privacy and safety, all things that I think we should consider, but I guess I don't know the answer to that yet. Yeah.
I'll let Microsoft know your data set's public.
With your limitations and barriers to exercise that you were able to collect from the people with OA, was there one repeating negative kind of element that would come up that people with OA said, this is why I'm not exercising, as outside of just general pain? Was there something that they had a poor connotation with exercise previously, like middle school gym class, or some sustained level, which does happen, of why people have some negative perception of what exercise is over time, compared to, you saw the two groups that you said that kind of already do exercise have higher mindsets for exercise because they like to exercise, so they exercise and they like exercise more. So that group that was just on drugs only or whatever, was there a key barrier that struck out to you that was like, oh, this is an interesting thing outside of just pain?
Yeah, that's a really great question, and I think the one-on-one interviews I conducted were probably the most insightful surrounding that, and I was able to sort of find some themes regarding how people viewed exercise. And actually, a lot of the literature had been around why people aren't exercising, but I wanted to learn, if we're going to change mindsets, we need to give people something more positive to think about. So I actually sought out individuals who were still really active, and found that those individuals tend to be people, like you were saying, who had good experiences with exercise throughout their entire lives. They did sports and other activities growing up, and then when they had osteoarthritis, they tended to just find ways to modify what they were doing to still be able to stay active, versus individuals who tended to not have been active prior to their diagnosis, and then when they have this additional barrier of pain, it kind of even further, I think maybe solidifies their mindset that they don't want to exercise, and I think that can kind of form this negative feedback loop. We hope that with a shift in mindset that goes just beyond education, that when individuals will not just engage in exercise, but engage in exercise or activity that they find enjoyable and fun, and find ways to modify it so that they enjoy it, and that can kind of further support their mindset and kind of transfer them into more of a positive feedback loop.
Anything else? Oh, please thank Dr. Boswell.